Today's lecture we're going to talk about opioids. Our goals for today, we're going to start by reviewing the history of opioids. We'll talk about the pharmacology of opioids, and then we'll discuss more of the commonly used opioids in dentistry, specifically those that we routinely use with sedation. We'll talk about morphine, hydromorphone. We'll spend time talking about fentanyl, Demerol, and then the reversal agent naloxone. First, we'll start off with a little historical perspective. So as far as the history of opioids, one of the things I like to start out with is discuss why opioids are so commonly used in medicine and in dentistry. And there's a lot of different reasons, but the first is that opioids provide some systemic or physiologic effects that are often quite useful for what we're trying to accomplish in medicine and dentistry. The first that you see here is that opioids provide or do a good job of providing analgesia, both from an intraoperative and then certainly from a postoperative perspective. And that's one of the main reasons why we commonly use opioids in dentistry. They're also a pretty potent antitussive, which is a cough suppressant. Obviously, this is a reason that it's more commonly used in medicine, not quite so common in dentistry. And then the other thing that's more of a side effect, certainly, but can be a therapeutic effect depending on what we're trying to accomplish, is opioids do provide or have some constipating effects. The diagram you see on the right, though, one of the main reasons that we tend to use them is because when we combine them with other medications, it allows us to get this balanced anesthetic model where we use different drugs to provide different effects that really kind of help accomplish. Obviously, there's some drawbacks from opioid use. The first and foremost, or the one that's most often discussed, is that opioid analgesics do cause respiratory depression. Certainly, at its most severe, that would be apnea, which is obviously problematic. They have several other effects as well. They can cause urinary retention. Certainly, they're pretty known to cause some sometimes significant nausea, vomiting. They can cause some sedation, unwanted constipation, and then certainly, these medications are known to have or to be causative in terms of initiating tolerance and then also chemical dependence. And this is really seen more often with patients where we're looking at repeated or prolonged use. Often in dentistry, we're providing these medications on a very acute or short-term basis, and it's usually not that much of an issue for us. When we have patients that come in week after week after week, though, that this is often more than 2 weeks, that's really when we start to see or can have increased risk of dependence and tolerance. Historically speaking, we'll start with morphine and codeine. These are both natural derivatives of opium. Opium comes from the poppy plant, which is what you see in the upper right picture. And then when they dry, it's actually kind of like a juice that they then dry out, and then they obtain from that this kind of powder. The dried opium powder contains about 5 to 20% morphine, and then a smaller portion, about 0.5 to 2.5% of codeine. There's other products or byproducts there, but none of those byproducts really have any sort of analgesic properties, so they're really not of any use for us. The juice from the poppy has been documented throughout history. The first documented use was back in 1550 BC in Egypt, so you can see it's been around for quite some time. Morphine was first isolated and named in 1806, and the person who invented it, first isolated it, named it after Morpheus, the Greek god of sleep, because that's one of the side effects that it does produce. Now, before we move on, I want to just briefly review some concepts relating to pain. And so we'll start with this. This is really step one is the signal initiation. And so you can see in this diagram we have the diagram on top labeled A, and this is where we see our primary activation. So we're going to pretend that in this diagram what we're doing is we're taking a scalpel and incising along the gingival mucosa. And as we take that scalpel and incise along that mucosa, what we're doing is we're damaging the cells that are, that the scalpel's cutting. And as we damage those cells, what we get is release of a lot of the intracellular substances. So we see, potassium ions spilling out. We see prostaglandins. We see hydrogen ions as well. If we inadvertently, cut through any small blood vessels, that's going to release bradykinin. And all these intracellular components really serve to activate or stimulate those primary afferent nociceptor, which is the nerve that we see here. All right, and so once we trigger or initiate the signal, then that is going to continue up along the nerve, ultimately reaching its way to the brain. Once we have, and that's kind of called primary activation. Now, going along with that, we see this secondary activation, and this is what happens after the fact, where we've already had damage to the area. We've got localized tissue damage, and then what happens is we kind of get this soup, this inflammatory soup that kind of occurs, and it gets built up, kind of occurs over time. And I'm sure we've all had this happen where, we've injured, let's say we sprained our ankle, and yes, it hurts in the area immediately. But then if you wait an hour or so, your whole ankle is really, really sore and sore to the touch. And what happens is once again we get this kind of inflammatory mediator soup that occurs. We get bradykinins and substance P. We get other inflammatory mediators from the mast cells and platelets that all kind of serve to rev up or predispose the other primary afferent nociceptors in the area, so that any sort of triggering can result in pain. It's kind of felt as pain. Now, looking at how that signal is transmitted from the periphery up to the brain, the two main, we can see here, this is a little diagram that shows us a variety of different nerves. We can see on top, that's our A fiber, the beta fiber. You can see that it's a myelinated fiber, so that would be one that would innervate, skeletal muscle. But the two that we're going to focus on are the A delta and the C fibers. You can see if you compare the difference between the A delta and the C fibers, they're both very small, but the A delta fibers have myelination. So you can see the myelin sheath that kind of surrounds along with the nodes of Ranvier. The other thing to take note of is that the C fibers don't have any myelinations. Next, in this diagram, what we'll see on part A here, you can see that we have the injury in this diagram. We'll pretend once again that the injury is an incision in the gingiva, and what we get is that initial section of nerve there leading from the injury to the spinal cord. That's the primary afferent nociceptor. Obviously, we get a synapse within the spinal cord. And then the nerve impulse is transmitted upward via that secondary afferent nociceptor, and it obviously passes up through the spinal cord, up through the medulla, the midbrain, and then ultimately synapses within the thalamus to a tertiary nociceptor, which is going to terminate somewhere in the cerebral cortex. And so there's a couple different sites where we see that kind of synapsing occur. The other thing to take note here is that if we're able to stop that impulse at any of the different levels, and we're able to prevent that impulse from ever reaching the cerebral cortex, then effectively the person is not, or the patient's not, going to be aware of the injury having had occur. The signal has to make its way to the brain in order for the patient to quote-unquote feel pain. So in part B here, what we see is you can see that the black line represents kind of the normal the normal pathway of pain, and you can see that the red lines on part B indicate this kind of descending inhibition, where we have at these specific areas within the midbrain, medulla, and spinal cord, we get. So one of the reasons that we like to review this process is because this is one of the ways that that opioid agonists work. They interact with opioid receptors that reside within the central nervous system and also within the peripheral nervous system, but the main effect that we tend to see is within the central nervous system itself. There are opioid receptors that reside within the midbrain, the medulla, and the spinal cord that really serve as these inhibitory centers that really stop or significantly retard the upward flow of information. And so this is called like descending pain modulation. Okay. And you can see that, and this is kind of what we see in the diagram to the right. You can see that the midbrain, the medulla, and the dorsal horn of the spinal cord are really where these receptors and this activity occurs. We also see some activity within the peripheral nervous system. We'll talk about that in just a minute. Furthermore, it's important to understand that within each of these different locations, we have a whole host of different opioid receptors. And so we'll talk about the different opioid receptor types in a minute, but it's important to understand that there are several different ones and that the clinical effects that we see really depend on which of those subtypes we're able to turn on. As I mentioned before, opioids also have activity within the peripheral nervous system. So here we see, this is a diagram that looks like our primary afferent nociceptor. And so we can see here's our nerve. And as you can see way out on the left-hand side, you can see that the different signal initiators can be either triggered by heat, injury, or some sort of change in the pH. And you can see that that's obviously going to trigger a signal initiation, and then that's going to start your wave of propagation, basically your nerve impulse traveling down the length of the nerve. Now, the main thing that we tend to use in dentistry and certainly in medicine as much as we can to combat this, we're going to administer our local anesthetics, and so those are obviously going to work on our sodium channels, and that's going to stop that nerve impulse from ever reaching. It's going to essentially stop that nerve impulse from traveling the length of the nerve. Once again, if the signal never makes its way to the brain, does the patient feel pain? No, they don't, right? So the other thing that we see on here is that we see opioids in two different places. We can see them way out at the end of the primary afferent nociceptor, and also within the synapse between the primary and the secondary afferent nociceptor. And in both of these locations, the opioid receptors are going to serve to significantly depress or turn off, slow down essentially that nerve impulse from being transmitted. So as I mentioned before, there's several different opioid receptor subtypes. The two that we're primarily going to focus on are mu1 and mu2. Mu1, as you can see, is listed here along with mu2. We can see the different clinical effects that we see. So mu1 is associated with bradycardia, sedation, itching, and then supraspinal analgesia. So that's the main reason that we're certainly using it, is we want those supraspinal analgesic effects. Mu2 is kind of a lot of the bad effects, if you will, and we can see that the main one that we see there that's of significant notice is respiratory depression. I talked about that before, but we can also see this is mu2 is specifically associated with dependence, itching once again, and kind of this high that you get, this euphoric feeling that you can get when you take these medications. It would be ideal if we had mu1 specific drugs, but as of yet we don't have any medications that are specific to mu1. All of our opioid agonists are able to, they're really non-selective. They have agonistic activity at both mu1 and mu2. Here we can see some of the other opioid receptor subtypes. We see kappa. We see some spinal analgesia, once again respiratory depression. As you look at the other ones, we can see hypertension, tachycardia, dysphoria, once again a little bit of spinal analgesia and respiratory depression at the bottom. And so, we get some activity of these receptor subtypes as well as with the mu receptor subtypes with a lot of our opioid agonists. Some other medications have activity here as well, such as ketamine. We get a little more kappa activity with ketamine as well as mu. And so we can get some analgesic properties or effects from some other medications as well. Looking at exogenous opioid agonists, these are opioid agonists that are not inherent to the body. And they can be categorized a variety of different ways. As we see here, they're categorized whether or not or how they're made. So we have our naturally occurring opioid agonists. This would include like heroin, morphine, codeine. We've got our semi-synthetic group. That would be like hydromorphone, hydrocodone, and oxycodone. And then we've got our pure synthetic ones. That would be like fentanyl, meperidine, and methadone. We also have our endogenous opioid agonists. These are our opioid agonists that are inherent to the body. So these are all natural. So these would be like endomorphins, endorphins, enkephalins, dynomorphins. These are the chemical mediators that are, once again, inherent to your body. And they're the things that are released when you do something that makes you feel good. So, those of you that if you're runners, you know that when you're done with your run, afterwards you feel really good. That's because we get a release of these naturally occurring endomorphins or endorphins, and they act just like opioid agonists do. It's just that they're produced within the body, and so they give you those same feelings of euphoria. You know, they remove a lot of, we'd get some analgesia with them, so it can take some of the aches and pains from running away, but they're naturally occurring. Also, we can get another group that we can get here is this mixed opioid agonist-antagonist group. And these are medications that have both agonistic and antagonistic properties. And so we get a little bit of each. They've got, you know, both activities essentially. All the previous medications that we've talked about, the naturally occurring endorphins, and then your naturally occurring semisynthetic and synthetic opioid agonists, all are pure agonist. This group, however, is a little different. This would be like buprenorphine, nalbuphine, and toluene or pentazocine. These have both activities. And then finally, on the other end of the spectrum, we've got our opioid antagonists. And the main one that we have here is naloxone. And it's really a competitive opioid antagonist. So when we administer naloxone, it's going to competitively inhibit or bind to the opioid receptors. Essentially, if there's enough of it present, it's going to push the opioid agonist out of the way. But it's going to bind to the receptor site without triggering, you know, without causing any sort of clinical effects. So it essentially reverses the activity of our opioid agonists. Now let's talk a little bit about opioid pharmacology. We'll look at some of the central nervous system effects, respiratory, musculoskeletal, cardiovascular, and some of the other effects that we tend to see. We'll start with the CNS effects. Obviously, the main reason that we're administering these medications is because of their ability to produce analgesia. And so these medications, no surprise here, they elevate the pain threshold. Now, the reason that we like to give these medications, not only is it to reduce the patient's perceived pain when we're providing some sort of pain-producing surgery, but also a lot of the medications that we give to produce sedation and cause amnesia, they can lower the threshold slightly. And so these opioids counteract the activity of our benzodiazepines and barbiturates. Additionally, these medications also blunt the upper airway reflexes, so they're commonly given after induction or during induction to blunt the airway reflexes, which is useful if we're going to intubate the patient. That way they don't respond as well, they don't feel it, they're not as stimulated. And that's going to primarily be done because it's going to reduce the risk of an intraoperative or during intubation laryngospasm. It's also important to know that very high doses can cause sedation or hypnosis, but it's especially important to realize that the patient's going to be sedated, but there are no amnestic properties. They'll remember everything, okay? They're just going to be nice and relaxed. Also, whenever we administer opioids along with other anesthetic agents, the opioids serve to reduce the requirements of the patient, the anesthetic requirements. Essentially what I mean by that is if a patient's going to require 100 milligrams of propofol to become deeply sedated, if we mix in some fentanyl as well, an opioid agonist, maybe we don't need 100 milligrams of propofol, maybe you only need 80 or 75 or maybe even 50. Also, because these opioid agonists take away a lot of the surgical stimulation, it really kind of serves to essentially smooth out the sedation. It just makes patients tolerate things a little bit better. And so it's commonly used as what we like to term a balanced anesthetic technique. And what I mean by that, I've kind of talked about it before, it's where we administer a variety of different medications that all kind of have different activity. And by combining them all together, we're able to really balance, provide this kind of balanced anesthetic technique where we give a little bit of, an opioid agonist, maybe a little bit of a benzodiazepine, and then we're going to add in our local anesthetic, and that allows us to really effectively provide a good, stable sedation for a patient. The opioid agonist is there for the analgesia. The local anesthetic is there to further take away any sort of surgical stimulation by providing local anesthetic. And then our benzodiazepines added to really provide the amnesia that we don't get with either of the other two medications. It also serves to give us a little bit of muscle relaxation and then certainly a pretty potent anxiolytic agent as well. Some of the other CNS effects that we can see meiosis or pupillary constriction, and that's a nice picture that we see here. And that's really done, it's triggered via the stimulation of the Edinger-Westphal nucleus of the cranial nerve 3. And so one of the ways that we can really tell, if a patient's overdosed on opioids, in addition to monitoring the respirations, is we can just simply take a look at their eyes. And if we see really profound pupillary constriction, then that's a pretty good signal that they've got some sort of opioid agonist on board. One of the other effects we like to talk about, opioids are pretty good at stimulating the chemoreceptor trigger zone. This is located within the area postrema, which is a kind of important part of the brainstem. It actually resides on the blood portion of the blood-brain barrier, and the reason it's there is it kind of serves as like a filter or a monitor to kind of monitor the blood for any sort of toxins that are going to make the the person sick. And so opioids do have some activity there, and their activity there is really responsible for causing the intraoperative or postoperative nausea vomiting that we often get with our opioid agonists. One of the other main effects that we see are certainly the effects of opioids on the respiratory system. As I mentioned before, the respiratory depression is one of the biggest problems that we have with opioid agonists. So the opioids, whenever we administer opioid agonists, it's going to cause dose-dependent respiratory ventilatory depression. So essentially what we see is we see a blunting of the response to an increase in carbon dioxide, and it kind of resets the patient's starting point as far as what triggers an increase in respiratory efforts. So remember that the patient's respiratory drive in a normal healthy patient is essentially triggered by any increase in carbon dioxide. So if you stop breathing for a second, the carbon dioxide starts to build up in your blood, and the chemoreceptors in the medulla essentially are responsible for monitoring those changes, and when they sense that these levels are increasing, it sends a signal to the the lungs and say, hey, we need to breathe. Okay. And opioids work at these chemoreceptors to kind of blunt that response. And so if we look at the graph on the right, now some of the other respiratory effects that we tend to see with opioids really pertain to the respiratory rate changes and then changes in tidal volume and minute ventilation. One of the big things that we see with the respiratory rate is that the respiratory rate will decrease. We'll see a drop in the number of breaths per minute. We see inverse changes as it relates to tidal volume, where we'll typically see an increase in the tidal volume. And so if we look at the right-hand side, we can see these are our Kaplan graphs, and we compare before opioids to then after opioids. And you can see that in the upper before opioids kind of picture, we can see that the respiratory rate is actually pretty quick. We see a lot of up and downs, and so those up and downs reflect the patient breathing in and breathing out. And if you compare that tracing to the one where it says after opioids, the big change that you see is that the number of breaths dramatically decrease. We're anywhere from down to maybe 2 breaths. But you can see the breaths are really, really long, and so typically we'll see really slow, big tidal volume breaths when we administer opioids. As far as minute ventilation, that's defined as the number of liters per minute. We'll see a slight decrease in the minute ventilation. Some other effects that we tend to see, there are some musculoskeletal effects. The most important thing that we'll see here, it's important to understand that essentially high doses of opioid agonists, or especially with certain very fast-acting onset opioid agonists like fentanyl, can cause some musculoskeletal problems. These high doses or rapid doses can cause these skeletal muscles to become very rigid and almost board-like. And so certainly the muscles in the chest wall are no exception, and we can get chest wall rigidity. And this can be so bad that essentially the chest wall is not able to move. And if it's not able to move, then we're not able to ventilate the patient adequately. Oftentimes, one of the first signs of this that we see is usually it's a small cough. The patient will kind of a little bit of a cough, and then we'll be unable to ventilate the patient. Now, if this occurs, obviously it's problematic because we're not able to ventilate the patient even with a bag mask because we can't get the air in. The chest is non-compliant. It's effectively like trying to ventilate a tabletop. And so whenever we have this, one of the first things we need to do is recognize it, and then it often can require emergent paralysis with succinyl choline. So this effect is usually prevented by using smaller doses of opioids And this is one of the best ways around this is really kind of titrate up. I'm not going to give maybe a bolus of 200 mics of fentanyl. I'm going to give it, 50 mics. Let's give another 25 and titrate in a few more, another 25 or so. And we're going to do that over a little bit of a period so that we're not giving these massive, initial bolus up front. We can also administer them very slowly. And then another thing that's kind of interesting is if we administer these medications with concurrently with, let's say, a benzodiazepine or some other central nervous system depressive agent or a muscle relaxant, certainly that's going to take away any sort of the risk of chest wall rigidity. From a cardiovascular standpoint, at normal doses, these opioid agonists are actually pretty stable, and they don't really cause that much of a significant change in the cardiovascular function. We can see a slight decrease in systemic vascular resistance or blood pressure, and we can also see maybe a decrease in heart rate as well. Most of these cardiovascular effects are due to the removal of the whatever stress, the surgical stress, that painful stimulation, we're taking it away. So we can also get a little bit of a sympatholysis that really stems from effects within the vasomotor center of the medulla. And then, by taking away the sympathetic tone, that's going to lead to a net increase in the parasympathetic tone, which once again is primarily via the vagus nerve. So once again, at normal doses, the cardiovascular effects that we may see a very minimal depression of the myocardial function, but the heart's usually able to maintain its cardiac output, so essentially no real net change there. We may see a slight drop in systemic vascular resistance, and we may see some mild bradycardia. Some other systemic effects that we see, obviously there's GI effects. We talked about the constipation before. It can be so severe that we can cause an ileus, which is decreased or lack of GI movement. So that can be pretty disconcerting for patients. We can see some hormonal effects. We can see a decrease in the stress response to pain. And we can also see histamine release depending on which agents we're using. This histamine is usually non-IgE mediated release of histamine from mast cells. And it's really common with these naturally occurring opioids, things like codeine, morphine, heroin, things like that. The synthetic opioids really don't trigger this at all, so it's really more of a concern with these naturally occurring opioids. Moving on, we'll talk now about some of the more specific opioid agonists. We'll look at morphine, hydromorphone, fentanyl, and meperidine. Morphine, otherwise known as Duramorph, it's really the prototypical opioid analgesic. Once again, it's a pure opioid agonist, and it really serves as kind of like the base equivalent and allows us to compare and contrast other opioid agonists. It's kind of the gold standard as far as comparing these opioid medications. And so you can see here, this is a dosing and conversion chart for opioid analgesics, and I find that these charts are actually pretty useful whenever we have chronic pain patients that come in, and let's say they're on a methadone, and they've got a daily dose of methadone, and then we're going to need to give them some additional pain medication, but you're trying to figure out how much or maybe what kind of agent you want to use. You can use these charts to kind of compare, okay, well, how much methadone are they taking on a daily basis? What does that equate to in terms of morphine if I give it to them PO or IM or maybe IV? And so you can kind of work backwards and find out what their daily dose is, and then add in either a different agent or add in some more of whatever they normally take, and this will kind of help give you some baseline as far as converting all that. Morphine is typically administered either IV or PO, but it can be given either intramuscularly, rectally, etc. So there's a variety of different ways that we can get it. It's primarily metabolized in the liver, and then what's of clinically relevance here, or clinical relevance here, is that it does have active metabolites. The two metabolites of morphine are morphine 3 glucuronide and morphine 6 glucuronide, and morphine 6 glucuronide is of particular importance because it is the active metabolite. So when it's around, it does have some analgesic and respiratory depressive effects. Morphine 3 is a non-active metabolite, so essentially we're not really worried about it at all. As far as the features of morphine, the typical effects that we see with opioids, that's what we're going to get here, and it's it's kind of interesting that no other opioid has been shown to be superior in terms of analgesia. Now, obviously, there's differences in terms of dose, but in equipotent dosages, you compare, equipotent hydrocodone or hydromorphone to morphine, they're all about the same as far as their ability to produce analgesia. Looking at the PO dosing for postoperative analgesia, for adults, typically it's anywhere between 10 to 30 milligrams PO every 3 to 4 hours. There is an extended release formulation. You can see here that it's only given every 8 to 12 hours. You can see the pediatric dosing down below. In terms of if we give this medication PO, oral morphine, the onset's about 30 minutes to 45 minutes. And remember that morphine's got a very low lipid solubility, so it's going to really take a long time for this drug to kind of take effect. We don't see the peak effect for about 45 to 60 minutes, and it's going to last about 2 to 3 hours. You can see it's primarily excreted in the urine and a little bit in the feces as well. As far as IM dosing for intraoperative or perioperative analgesia, the dosing is usually 0.1 milligrams per kilogram. You can see the pediatric dosing there as well. It's got a little quicker onset. It's about 10 to 20 minutes, which really reflects the change between PO versus IM. But once again, this drug is very lipid insoluble, so it's going to have a very, very delayed or slow onset. You can see the peak effect. Really, we don't see it for about an hour or so. Once again, the duration's about the same, and that's one of the problems with using morphine is that we do not see the peak effect very quickly. And so if I'm a provider of anesthesia and I'm going to be giving medication, I want to know that I've seen the peak effect, because that enables me to say, well, you know what, in this patient, we've seen the peak effect, it's not enough. The patient's still in pain, I want to give more. With morphine, because it's so delayed, we really have to wait and wait and wait to make that judgment as to whether or not we've seen the peak effect. And that's what really makes this drug relatively difficult to titrate. Here we can see the IV dosing, once again for intraoperative or perioperative analgesia. You can see it's typically 0.05 to 0.1 milligrams per kilogram. One of the ways that I like to teach on how to give morphine, if we're going to use morphine, is we're going to calculate our initial dose, and then we're going to give about 75% of that, and then we're going to wait and see, give it about 10 to 15 minutes, and we'll see what kind of effect we get. And then if it's not a strong enough effect, then we're going to go ahead and titrate in some more. The onset with IV is about 10 to 15 minutes, so once again, it's actually pretty delayed, and the peak effect is about 20 to 30 minutes. So once again, that's pretty far out there, and it really, really is hard to kind of sit there and wait and wait and wait. Once again, with anesthesia, we typically want to give drugs and see an effect now, so with morphine, we really don't have that ability to really very clearly titrate in to the level we want. It just takes such a long time. Morphine does have some special indications. One of the ones that we look at here is once again the MONA protocol for patients with suspected of having a heart attack or a myocardial infarction. MONA stands for morphine, oxygen, nitroglycerin, and aspirin. And then any patients that are present with a suspected acute MI or unstable angina, this is where we're going to institute our MONA protocol. And the morphine dosing for this is 2 to 5 milligrams via IV every 3 to 4 hours. And why morphine is indicated here is because it does a couple different things. Number one, it's going to cause or produce some analgesia, which is good in this case if the patient's having chest pain. And so the morphine is going to help alleviate that chest pain, and that's going to lead to a decrease in the sympathetic tone. So it's going to lead to a lower heart rate, a lower blood pressure, which is what we want. It's also going to produce a little bit of anxiolysis, which is going to further reduce the sympathetic tone, and all that serves to really decrease the stress on the heart. Now, the other effect that we see, which is of a unique importance to morphine, is that morphine causes histamine release. We talked about that a little bit ago. And that histamine release is going to lead to vasodilation of the coronary arteries. That vasodilation is good because it's going to open up the blood vessels and hopefully help reestablish blood flow to the infarcted areas. We do not get that histamine release with our synthetic or semi-synthetic drugs. So, could you give, hydromorphone or Dilaudid, for example? You could. It's not going to cause the histamine release, but it will serve to reduce the pain. Next, we'll talk about hydromorphone or Dilaudid. It's a semi-synthetic opioid agonist. It's one of my more drugs I use more commonly. It's approximately 10 times as potent as morphine, so it's a lot stronger. And so we dose dependent wise, we're going to have smaller. Instead of giving 10 milligrams morphine, we're going to give 1 milligram of Dilaudid. As far as how this drug is administered, usually it's administered either IV, most commonly. It can be administered IM or certainly PO as well. From a pharmacologic standpoint, it's metabolized in the liver, and then what's really nice about this drug is it doesn't have any active metabolites, so we don't have to worry about that. It's a very clean drug. The onset of Dilaudid or hydromorphone is very quick. You can see the IV onset's about 2 to 3 minutes, and we see the peak effect in about 5 to 10 minutes. So if you compare to morphine, remember morphine took about, even IV, it took, as far as the indications, the main indication for Dilaudid, certainly for what we're using it for, is analgesia, either perioperative or postoperative. So you're going to give it postoperatively for pain management. It also has a pretty good antitussive, so you can give it if the patient is complaining of coughing. It comes in a variety of concentrations. Usually it's either 1 or 2 milligrams per ml, and so one of the easiest ways is to go ahead and take and dilute that down into a 10 cc syringe so that it's either 0.1 or 0.2 milligrams per ml. As far as the analgesic dosing for adult and pediatric, they're listed below. You can see the adults usually 0.1 to 0.2 is our initial bolus, and then we're going to slowly titrate to effect. So we'll give our initial 0.1 to 0.2, and we'll see how the patient's doing. If they are breathing still very rapidly, we're going to give another 0.1 or 0.2 bolus, wait a few minutes, see how they're doing. If they need more, give them more. So we can really effectively titrate to the endpoint that we want. The next drug we'll talk about is fentanyl. Fentanyl is another, it's a synthetic opioid agonist. It's a piperidine structure. You can see the structure on the upper right-hand side. It's 100 times more potent than morphine, and so you can see that it comes in 100 mic per 2 ml vials commonly. And because it's so potent, it's very much at risk for causing chest wall rigidity. We don't see that with with Dilaudid or with morphine. We can see that with fentanyl. As far as the routes of administration, typically it's given IV or IM, typically IV, but it can be PO as well. They make fentanyl lollipops that have been used for chronic pain patients and pediatric patients. Don't really recommend those, but they can be available. As far as the drug metabolism, it's metabolized in the liver, and then once again, like Dilaudid, there are no active metabolites, so it's a very clean drug. We don't have any sort of hangover like we can get with morphine. With the onset with fentanyl, when it's given IV, the onset's about 30 to 60 seconds, so it's a very, very quick drug. And that really reflects the lipophilic nature of it. It's very lipophilic, so it's able to penetrate through cell membranes very, very easily and very, very quickly. And so this drug is going to have a very, very quick onset. As far as the duration, given IV, the alpha half-life is about 30 to 40 minutes. And we see a peak respiratory depression that occurs about 5 to 15 minutes after the initial bolus. So it takes a little, we get that initial onset and that peak effect, but we don't see the respiratory depression component for a little bit of time, about 5 to 10 minutes or so. Of potential note is that we can get in some patients, the respiratory depression can still be present, much longer, about 4 hours later. So we can see that in a select few patients. The main indication for fentanyl, once again, is perioperative analgesia. It's supplied a lot of different ways. As I mentioned before, this is a picture of the fentanyl lollipop. It also comes in fentanyl patches for chronic pain patients. It's important that the chronic pain, or the fentanyl patches, we really don't use that often for postoperative analgesia for dental procedures. But it's important that if you are going to use those for whatever reason, that you're aware of how they work, so that the patients know not to put any sort of heating pad on it to speed up the release of the fentanyl, because you can get, a massive bolus of fentanyl, and then the patient can subsequently, die from respiratory depression. So, once again, we really don't use them. Usually it comes, as far as the IV solution, usually it comes in 50 mics per ml. Typically in 2 ml, so it'd be 100 mic total. It also comes in 250 mic total 5 ml vials as well. But for most sedations that we do, we're typically administering somewhere between 50 to 100 mics, so the 2 ml vial works great. As far as analgesic dosing, the adult, the dosing is typically 1 to 2 mics per kilo. So a 75 kilo adult, you're going to start about 50 mics, see what that initial bolus does, and if you need some more and you've got some more room to give some more fentanyl, then you're going to give the remaining 50 mics. And we're going to titrate slowly to effect. Now, fentanyl also has some cogeners, which some derivatives that have been produced. So you can see they're all relatively similar in their names. So the parent drug is fentanyl, and you can see the derivatives are alfentanil or sufentanil and certainly remifentanil. And these are all medications that structurally are very similar or related to fentanyl, but their structure enables them to have a quicker onset even than fentanyl, and to have a quicker or a shorter duration. Remifentanil is of particular importance because unlike the other three drugs, it's not metabolized in the liver. It's actually broken down by plasma esterases in the blood. And so that allows remifentanil to really be unique in the sense that we can provide continuous infusions of it for extended periods of time, and then essentially when we turn the infusion off, the rest, any sort of the remifentanil is essentially metabolized within about 4 to 8 minutes and essentially gone. It doesn't build up or accumulate like a lot of the other or all the other opioids do. And so that's really what we see in this diagram here. You can see on the y-axis, that's the time to get a 50% drop in the concentration at the effective site, which would be the brain or the central nervous system. And then below on the x-axis, you can see that's the duration of infusion. So how long, in terms of minutes, have we had these infusions of these medications going, and then we turn them off, and then it's how long does that take to get that resultant 50% drop in concentration. And of particular note, once again, you can see that remifentanil is essentially all by itself, and what that really shows is that it does not accumulate in the peripheral tissues. There is no reservoir of remifentanil. It's essentially, once we turn the infusion off, about 48 minutes, it's effectively gone. The other thing of importance is to look at fentanyl, and it's totally different than all the other drugs in the sense that it's so lipophilic that as we infuse it, essentially you can see that it essentially starts to build up in the tissues, and it takes an extremely long time for it to go away. Next, we'll move on and talk about meperidine or Demerol. It is a synthetic phenylpiperidine structure. Looking at the structure of it, you can see that it's essentially unrelated to morphine, and on a molecular basis, it actually resembles atropine. And because of that, we actually see some of the similar effects that we get with atropine. We can see those vagolytic effects. Primarily, what we tend to see is tachycardia. Meperidine is somewhat unique as well, is that it can also cause histamine release. A lot of the other synthetic opioids don't, but this one particularly does. It's kind of unique in that regard. Typically, as far as administration, it's usually given via IV, IM, or PO, and it's metabolized in the liver. Similar to morphine, this drug does have active metabolites. The active metabolite for meperidine is normeperidine, and it's of particular importance. We'll talk about that in a minute. The onset with meperidine is pretty quick IV. It's 2 to 4 minutes, so it's a pretty lipophilic drug. Not quite as quick as fentanyl, but still relatively fast. The duration is about the same as fentanyl. It's about 30 to 45 minutes. And you can see that as far as elimination, meperidine lasts anywhere between 2.5 to 4 hours, and that active metabolite, though, is really the problem. It sticks around for about 15 to 30 hours, so that's quite a long time. Looking specifically at that active metabolite normeperidine, the reason that it's so unique is that not only does it stick around for a really long time, but it also is a very potent proconvulsant. It's going to lower the seizure threshold, and so patients are likely to have, or not likely, but they can have seizures or seizure-like activity if they're given meperidine. Also, normeperidine has about a 50% lower analgesic effect compared with the parent drug. Normeperidine is also associated with a couple different complications. We typically can see these complications if we're giving meperidine chronically. So if you're giving, PO meperidine for postoperative pain, the increased dose, because of the increased duration, is likely to cause some sort of complications. Also, if we give very large doses, or if we have patients with impaired renal function, we're going to get impaired, or we're going to we're going to start to accumulate that active metabolite, that normeperidine, and so that's going to lead, because we're not able to excrete it as easily, and so that's going to lead to an increased likelihood of complications. As far as the indications for meperidine, certainly it can be used for perioperative or intraoperative analgesia. It can be used for postoperative pain control. However, I think because of the kind of unique problems that are associated with Demerol and meperidine, I think there are some other cleaner drugs, and this really is kind of an antique drug, I think, more than anything else. The one main indication that I kind of personally use meperidine for is it can be used to treat postoperative shivering after a general anesthetic. You can give very small doses of it, and you can actually titrate to the point where patients will stop shivering. And that's really the only reason I use Demerol anymore. It is, once again, kind of a dirty drug. It does have some contraindications. There's an increased risk of serotonin toxicity, and that can be fatal if these drugs are given to patients who have concurrent use of MAOIs, tricyclic antidepressants, SSRIs or SNRIs. So we do need to be aware and be careful of patients on those medications. And really, once again, because of these, I think it's better to use something else, something cleaner like fentanyl. Also, patients with a history of any sort of cardiovascular disease, or a history of myocardial infarction, coronary artery disease, etc., because of the atropine-like effects that we see with Demerol, we're going to get an increase in tachycardia, and then we're potentially going to get some hypotension. And those two in combination are really not ideal for patients with this history of cardiovascular problems. As far as PO, IV, or IM dosing, you can see that Demerol, we can see the dosing down below as far as the intraoperative or postoperative pain. Usually it's 50 to 150 milligrams every 3 to 4 hours. You can see it comes in a variety of different ways, either in a tablet, oral solution, or injectable solution. And so we're just going to kind of use whatever we need to. Like I mentioned before, the main reason that I use Demerol anymore is really exclusively for postoperative shivering. For that, I'm going to utilize the injectable solutions, and then once again, we're going to use very, very small amounts. And so with adults, we'll start with 6.25 milligrams, maybe 12.5 milligrams. We'll give it IV, give it a few minutes, and really kind of titrate just until we get the shivering to kind of stop. Next, we'll talk about some opioid reversals. This is the use of Narcan or naloxone. As I mentioned before, naloxone is a pure opioid antagonist, and so it's really effective for reversing the effects of either pure agonists or partial agonist antagonists. So the main indication where we're going to use naloxone are on patients that have an acute opioid toxicity. Essentially what we've done is we've overdosed them and we've triggered a respiratory depression or respiratory failure. They're not breathing as much as they should or at all, right? And so we need to reverse those effects. And so we're going to use naloxone, and because of its opioid antagonistic effects. The onset of naloxone is very, very quick. If given intravenously, it's essentially immediate. It's about 30 to 60 seconds. One of the ways I like to think about naloxone is in terms of pharmacology, it's essentially like fentanyl except backwards. All right, so it's very, very quick. We see the peak effect in about 3 to 5 minutes, and it lasts just about as long as fentanyl does. It lasts about 30 to 40 minutes. Narcan or naloxone can be delivered either IM, IV, or even if you squirt it down an endotracheal tube. However, for routinely, it's essentially given intravenously during an emergency, and that's because that's the quickest, most effective way to get the effects that we want. Technically, could you give Narcan via the PO route? You could, however, for an emergency, and remember, we're giving naloxone or Narcan for an emergency because we need to reverse the opioid-induced respiratory depression. If you give it orally, the effects are going to be so delayed that it's essentially worthless. So Narcan comes in a variety of concentrations, and so one of the things that I like to remind residents is that they need to be aware of how their medications come in their office or in their drug cart, and then be ready and prepared to convert or use them as needed. Typically, Narcan comes 0.4 milligrams per ml. It's a 1 ml single dose vial. That's what you see in the upper right hand side. And you can see that the dosing, we're going to dose this drug kind of differently depending on what the underlying issue is. For an acute opioid toxicity or emergency, this is essentially a code where the patient has overdosed, they're not breathing at all. We need to reverse the opioid effects and reverse. So now we're going to essentially give the whole thing. We're going to give a massive dose of naloxone as quickly as possible. So we'll give 0.4 to 2 milligrams. There's kind of a range there intravenously, and we'll give that every 2 to 3 minutes. So we basically would start with the whole vial, 0.4 milligrams, and then see if that was enough. If it's not, I'm going to give another 0.4, and then I'm going to repeat as needed. All right, you can see the pediatric dosing below. Now, if it's not an emergency and it's simply that they're still ventilating, everything's stable, but they're just, breathing, they're hypoventilating, so they're breathing maybe a rate of 2 breaths per minute or 4 breaths per minute or something like that, and we've effectively overdosed them, but everything's still stable, it's a non-emergency, then we can do it a little bit differently. We can give smaller boluses, so maybe we would give, a tenth of what we'd give for an emergent situation. Maybe we'd give 0.04 or 40 mics IV, and then we would repeat that every 2 to 3 minutes as needed. We'd essentially titrate to the desired level that we want. Once again, this dosing, though, it's important to understand that this is for non-emergent situations. Okay, if it's an emergency, we're going to give the whole thing intravenously and see, give it a few minutes. If it's not enough, we're going to give more. Thank you for listening. If there's any questions, please do not hesitate to contact me via email. Thanks.